Good evening, everyone. We welcome you all to the series of webinars hosted by Yashoda Hospitals, Hyderabad, India. Uh, Today, we came up with an interesting topic based on the World Heart Day. I think we all know that tomorrow is the World Heart Day, which is going to celebrate around the globe on 29th September. So, we have picked up an interesting topic: general common scenarios, hypertensive emergencies. Often we came up with acute heart failure patients. One of the causative factor was hypertensive emergency. So today we are going to enlighten on those. Today we have two speakers from Yashoda Hospital, Somajiguda. Uh, Dr. Tapashri Reddy, she is the senior resident Department of Emergency Medicine, Yashoda Hospital, Somajiguda. She is going to present two cases based on hypertensive emergency as well as urgency. And then we have a senior interventional cardiologist here, Dr. Rohit Reddy. He is going to enlighten us about the how to approach the hypertensive emergency, and then how to deal with those, and then long-term management as well. And I welcome Dr. Kiran Kumar Verma. He is the moderator for this session, and myself. I think all of you know Dr. Suresh, head of the Department of Emergency Medicine, Yashoda Hospital, Somajiguda. So today we are going to start with case presentations first, and hand over to Dr. Tapashri to take over the floor. Yeah.
Hello everyone, I'm Dr. Tapashri Reddy, resident of emergency medicine at Yashoda Hospital, Somajiguda. Today we will be talking about hypertensive emergencies and their management in the emergency department. As we get a lot of hypertensive cases, it is very important for all of us to know how to differentiate different types of hypertensive emergencies and how to manage them promptly to give better patient care and to decrease the mortality and morbidity rate. My first case is regarding a 38-year-old male who presented to our emergency with complaints of class 4 dyspnea, which was sudden in onset and was progressive. It was not associated with any chest pain or palpitations. The patient had history of bilateral lower limb swelling, orthopnea, and decreased sleep since 5 months. There was no history of any fever or any other significant complaints. In our primary assessment, the patient was able to talk, so assuming airway is patent and protected. Breathing was spontaneous. He was a little tachypneic with a respiratory rate of 36 per minute, and saturations were 88% on room air. On auscultation, there was basal Krebs on bilateral side. Circulation heart rate was 126 per minute, and his BP was found to be 230 by 120 mmHg. The patient's GCS was 15 by 15, pupils bilateral reactive to light. His GRBS was 146, and he was normothermic. In our secondary assessment, the patient had symptoms of orthopnea on and off since the past few months. He had no known allergies. The patient was regular on his diabetic medication with glimepiride and metformin, whereas he was very irregular about his hypertensive medication. He was a known hypertensive since the past 6 years, diabetic since the past 5 years, and CAD status was PTCA 4 years back. His last meal was taken 4 hours ago, and there was no symptoms relevant to the current illness. In our diagnostic assessment, an advanced medical profile, NT-proBNP, and TROPI were sent. An ABG was sent in the ER, which showed hypoxia, and the lactates were a little high due to tachypnea and hypoxia. It was 4.06, and his creatinine was 0.97 mg per dl. His ECG showed sinus tachycardia with no significant changes. A chest X-ray was done, which showed back twin opacities and peribronchial cuffing, which was very evident for pulmonary edema. A 2D echo was done, which showed inferior wall hypokinesia, no RARV dilatation. There was a mild LV dysfunction, and the IVC was non-collapsing. This is the ECG as we see, only sinus tachycardia. TROPI and NT-proBNP were in normal limits. Regarding the treatment, the patient was started on O2 therapy with a face mask and 6-liter O2 and was maintaining on 96% saturations. Injection Lasix 60 mg bolus was given, followed by an infusion, and an NTG infusion of 0.6 ml per hour infusion was also started. A cardiologist was involved. We advised for a color Doppler study for renal arteries, which showed a negative study for renal artery stenosis. Ophthalmologist opinion was taken to rule out hypertensive retinopathy. After initial stabilization, the patient was shifted to cardiac intensive unit for further management. This is the first case which shows hypertensive emergency, which had two components. One is elevated blood pressure and the other is end organ involvement, in this case, which is pulmonary edema. Going to my second case, it is a case of a 32-year-old male who presented to the ER with complaints of severe headache associated with giddiness and palpitation since the past 4 days. The symptoms were of acute onset. Primary assessment, again, the airway was patent and protected. Breathing was spontaneous. Respiratory rate was 22 per minute and saturations were 99 on room air. Circulation heart rate was in normal limits, which is 84 per minute, and his BP was found to be 210 by 100 mmHg. His GCS was 15 by 15, pupils bilateral reactive to light, and GRBS was 132 mg per dl, and he was normothermic. In our secondary assessment, the main symptom was headache, which was acute onset. There were no known allergies. The patient was on no medications and had no previous known comorbidities. Last meal was taken 6 hours back, and there was no symptoms, no eventful symptoms related to the present illness. In our diagnostic assessment, ECG showed normal sinus rhythm, 2D echo with no RWMA, no RARV dilatation. There was a good LV function, and the IVC was non-collapsing. In addition to that, advanced medical profile and TROPI were also sent, and the blood works were in normal limits. This patient was treated with oral antihypertensives with calcium channel blockers, amlodipine 5 mg stat, and telmisartan 40 stat. Cardiologist was involved. Ophthalmologist opinion was taken to rule out hypertensive retinopathy, and the patient after stabilization was shifted to cardiac ICU for further management. This case, the patient had hypertensive urgency with no end organ involvement. Thank you.
Yeah, those are the two. That was a good presentation, Dr. Tapashri. Those were the two cases typical of hypertensive emergency as well as urgency, which we have treated over the last month. And so what next? Yeah, we have diagnosed hypertensive emergency as well as urgency. Then how to deal with initial approach, stabilization, and then a continue of the care and long-term management is going to be talked by Dr. Rohit Reddy. Yeah, I welcome Dr. Rohit Reddy to take over the floor and then enlighten us. Yes.
Thank you very much, Dr. Suresh. So it's my pleasure to be part of this discussion as a live program. At the outset, I would like to thank Dr. Suresh and the emergency department for giving me this opportunity to present on such an enlightening and intriguing topic. Though, hypertension is very well known, and hypertension is very well known to all the people, and most of the physicians, and even from the level of our MBBS days, many of us keep treating hypertension. There are very subtle points, which matter a lot in the management of the patients who present with extremely high blood pressure. In this case, what we call as hypertensive crisis. A hypertensive crisis can be an emergency or an urgency. So today, on the backdrop of the two very interesting cases which Dr. Tapashri has presented, I would like to present a few slides on what exactly is hypertensive emergency and how to treat hypertensive emergency and how to approach a patient with extremely high blood pressures. Okay, so basically chronic hypertension. So as defined by the ACC/AHA, now the definition of hypertension has come down to BP levels of less than 120 by 80 are known as normotensive, whereas 120 systolic of 120 to 140 and a diastolic of 80 to 90 are pre-hypertensive or stage 1 hypertension as per the ACC-AHA, and more than 140 systolic is stage 2 and more than 90 diastolic is stage 2 hypertension. So, the guidelines for the hypertension are keeping dropping every time the ACC and AHA meet or the JCC meet. So the reason for this is because in stage 1 hypertension, which is between systolic of 130 to 140 and a diastolic of 80 to 90, we need not treat the patient with medication, but they require management with diet control and physical activity. And but in the same group, if the patient has other risk factors such as diabetes mellitus and hypercholesterolemia, then they need to be treated with antihypertensive agents. So why exactly is hypertension important? Because chronic hypertension, as we call it, or elevated blood pressures, increases the risk of atherosclerosis, ultimately leading to coronary artery disease and myocardial infarction, and also cerebrovascular disease and renal disease in the form of acute kidney injury and chronic kidney disease. So these are associated with long-term risks. And sometimes elevation of blood pressure is often a physiological response to an acute condition, like we have seen many times in patients with acute glomerulonephritis, when the blood pressure becomes elevated as an acute condition. So coming to hypertensive emergency, what exactly is the definition of hypertensive emergency? So by definition, the hypertensive emergency itself does not have a definite value. It is nothing but a rapid decompensation of a vital organ function. In further, we will be reading this as target organs function, which is secondary to an inappropriately elevated BP. Let me note here that in such cases, it is extremely essential to determine the duration of elevation of blood pressure. Because if a patient who has chronic hypertension, for him to develop hypertensive emergency is very rare. So the duration in which the blood pressure rises is very important. An acute elevation of blood pressure leads to hypertensive emergency rather than a chronic elevation of blood pressure. And why is this important? Because it requires lowering of blood pressure within 1 hour to decrease the morbidity and mortality. And like I've already said, the hypertensive emergency by definition does not have a predetermined BP level, but it has essentially defined by the target organ damage or vital organ dysfunction. So when we say target organ damage, so these are the organs which can be affected. The first is the central nervous system causing hypertensive encephalopathy or a cerebrovascular accident or CVA, which we call brain stroke. It can be both ischemic or hemorrhagic. And the cardiovascular system causing acute myocardial ischemia or infarction, or acute cardiogenic pulmonary edema, acute aortic dissection, and in post-op vascular surgeries. And other target organ damage include the renal system causing acute renal failure, and if it happens multiple times can lead to chronic kidney disease, and eclampsia and HELLP syndrome, and can also occur cause catecholamine excess, such as in conditions with pheochromocytomia, and drugs such as amphetamine. So, hypertensive emergency is a condition, like we have already discussed, where we need to bring the BP down immediately. That is why it is called an emergency. So there is another term which is known as hypertensive urgency. This is a condition which is also called as hypertensive pseudo-emergency. That means there is no target organ damage in hypertensive urgency, but it is called urgency because the blood pressure, that is a systolic blood pressure, is more than 180 millimeters of mercury, and the diastolic blood pressure is more than 110 millimeters of mercury. Hence, the BP has to be reduced, but need not be reduced emergently. That means it can take time to reduce the BP. So it is nothing but potentially dangerous BP elevation without acute and life-threatening end organ damage. So in such cases, we try to reduce the BP gradually over a period of 1 to 2 days rather than a period of hours. So these are few causes of a hypertensive crisis. In a chronic hypertensive patient, the most commonly an abrupt increase in blood pressure can happen because of discontinuation of medication or progression of the disease itself. And also renovascular hypertension, parenchymal renal disease such as chronic kidney disease, and scleroderma and other collagen vascular diseases. And it can also be caused due to injection of drugs such as sympathomimetic agents, including cocaine, amphetamines, and LSD, and tricyclic antidepressants. And the most common, which we have discussed, withdrawal from antihypertensive agents, especially certain group of agents which are the centrally acting beta antagonists such as clonidine. It is known to have reflex hypertensive crisis. And in patients with preeclampsia, eclampsia, pheochromocytomia, acute glomerulonephritis, and acute head injury, and CVS, and ingestion of tyramine in association with the monoamine oxidase inhibitor, then renin secreting tumors, vasculitis, and also in autonomic hyperactivity in patients with GV syndrome or other spinal cord syndrome. So let me mention here, in the recent pandemic of the COVID pandemic, we have seen plenty of cases with autonomic dysfunction. And in these cases, they had very labile BP, and many of them were land up in hypertensive crisis requiring IV antihypertensive agents. And the BP was very labile, so that, ultimately they used to go into hypo and hypertension. And these were the subset of the patients who were on ventilator and had a poor prognosis after acquiring COVID. So in patients with hypertensive emergencies, or when the patient comes into the ER, our basic aim is to ascertain the cause of the disease. Yes, we need to reduce the BP immediately by using medication, but we also have to keep in mind why the blood pressure has been elevated to ascertain the underlying etiology and cause of the disease. So these are certain clinical findings of secondary etiology, which helps us in determining whether these are the causes for the elevated blood pressure and hypertensive emergency. The reason why we need to look at the underlying cause and the secondary etiology is to prevent further episodes of hypertensive crisis, rather than discharging the patient after blood pressure is controlled and the patient repeatedly coming back to the ER. We need to give a thorough examination and evaluation to the patient so that the patient does not return back in such a crisis. So, clinical findings would include signs of thyrotoxicosis, such as proptosis, tachycardia, and any evidence of thyroid storm, such as arrhythmias, and patients with both hyper and hypothyroidism can have hypertensive emergency. With hypothyroidism, they have associated bradycardia and myxedema. Any associated goiter should point towards thyroid etiology. And patients with hyperparathyroidism also have present with emergencies. They usually have hypercalcemia, leading to psychosis, constipation, and increased QTc interval, cataracts, and nephrocalcinosis. And because of hyperparathyroidism and hypercalcemia, they can have calcification of soft tissues, which can be diagnosed by a simple X-ray. Then others endocrine causes of hypertensive emergencies include Cushing's disease and Crohn's disease. So Crohn's disease is primary hyperaldosteronism, and the typical finding in this patient is hypokalemic metabolic alkalosis, which can be seen on an ABG. And the patients with Cushing's disease have elevated levels of glucocorticoids and hence have Cushingoid features, which have morbid obesity and abdominal visceral obesity with the purple striae and elevated blood pressures. So the other important endocrinological cause of malignant hypertension or hypertensive crisis is pheochromocytoma. In pheochromocytoma, there is elevation of levels of metanephrines and norepinephrines, which is produced by the suprarenal tumor and secreted into the blood. So they present with labile hypertension or orthostatic hypertension and labile blood pressures. And the typical characteristic of patients with pheochromocytoma is they have sudden elevation of blood pressure. Normally, their baseline blood pressure may be normal or controlled with medication, but they have sudden spikes at the time of which they can end up in hypertensive emergency or hypertensive crisis. So they have other symptoms such as perspiration, palpitation, and pain, and they can also have anemia. And the other important secondary causes include the renal artery stenosis, and a clinical examination and auscultation of the abdomen at the level of the renal arteries, that is on either side of the umbilicus, can demonstrate a renal fluid. And patients in pregnancy with hypertensive emergency can land up with eclampsia or pre-eclampsia or HELLP syndrome. And the most often underdiagnosed cause and the most often missed cause of hypertension, maybe chronic hypertension or uncontrolled hypertension on medication, is what we call obstructive sleep apnea or Pickwickian syndrome. It is typically seen in obese patients and short-necked patients. And it is essentially imperative for us to take a detailed history in such patients to elucidate any daytime hypersomnolence and any sleep apnea and excessive snoring during the night from their family members. So if any patient has such features, it is always imperative for us to do a sleep study to rule out obstructive sleep apnea, because obstructive sleep apnea is a very important secondary cause of hypertension. And unless the underlying sleep apnea is treated, despite giving medication, most of the patients do not have well-controlled blood pressure and then can present repeatedly to the emergency room with either accelerated hypertension, hypertensive urgency, or even hypertensive emergency. Okay. So basically, when you evaluate a patient for a hypertension or a hypertensive crisis, we call it, they have to be evaluated for the secondary causes. So I think we already do the complete blood picture and the renal function test. So based on the creatinine, we can see whether any renal involvement is there. And in the complete blood picture, we can see for anemia, the platelet count and the liver enzymes in the liver function test can help us in diagnosis HELLP syndrome. And thyroid TSH is mandatory for diagnosing hyper or hypothyroidism. And along with other endocrinological causes, if these are normal, we should also do the serum metanephrines and 24-hour urine metanephrine, normethanephrine. Along with it, we also need to focus on imaging to rule out secondary causes, such as an electrocardiogram, ECG, 2D echo to look for LVH, that is left ventricular hypertrophy, and any other cardiac disorders. And a CT iotogram can help in ruling out Takayasu arteritis, which is seen in young patients commonly in our scenario, and any rule out renal artery stenosis. But the most important and the most classification defining examination in a patient with hypertension would be examining the retina of the patient. So a patient with elevated blood pressures with evidence of retinopathy can be classified under accelerated hypertension. So that means elevated blood pressure with retinopathy is defined as accelerated hypertension. So this is a very old classification given by Keith Wagner classification. So retinopathy is divided into 4 grades: grade 1, 2, 3, and 4. So grade 1 is just mild generalized retinal arteriolar narrowing, and it is very difficult to make out for a novice. So only this can be detected only by experts such as the ophthalmologist or a neurologist who keep seeing regularly. As a part of a curriculum, actually during our MD days, we had to, in neurology and even in medicine, we had to see the retina of each patient. So that time we had developed the skill to pick up few retinopathy signs. But I can say we can pick up from grade 2 to 4, but grade 1 is very difficult. And grade 2 is a definite focal narrowing and AV nipping or arteriovenous nipping, like we call it. Grade 3 is signs of grade 2 retinopathy plus retinal hemorrhages, which include exudates and cotton wool spots. And grade 4 is severe grade 3 retinopathy plus papilledema. So all we need to remember is cotton wool spots and hemorrhages is grade 3 and papilledema is grade 4. So this is the retinopathy finding. So normally when we examine a retina, we may not be able to get such a clear picture. But still, if you can see here in exhibit around A and below, you can see clearly these yellow spots, which are deposited. So those are these are the red spots, which are the cotton wool hemorrhages, and the dilatation of the fundus, which is the papilledema. So these are the other investigations which aid in the diagnosis of chronic hypertension. So this is electrocardiogram, which is showing left ventricular hypertrophy. So the normal easy criteria, what we look for a left ventricular hypertrophy is the S wave in lead V1 or V2, and the R wave in lead V5 or V6. So S in V1 or V2 plus R in V5 or V6 should be equal to 15 big squares. That is 5 big squares or 15 small squares boxes. Then it is considered as left ventricular hypertrophy. Or in AVL, if the R wave is more than 11 millimeters or 11 small boxes, then it is considered left ventricular hypertrophy. So this patient has left ventricular hypertrophy. Along with that, he has some STT changes, which is as a result of left ventricular strain pattern. So we can diagnose him with left ventricular hypertrophy with strain. That means severe hypertension causing strain on the heart and requires immediate reduction of blood pressure. And this is the 2D echo of the patient. As you can see, this is the left ventricle in the short axis view, which is showing extremely thickened left ventricular myocardium. So normally, when you measure at the papillary level, the interventricular septum, it should be less than 1.2 centimeter. But here it is 1.8 centimeter. You can see clearly that this is the short axis view, whereas this is the long axis view showing the interventricular septum and the posterior wall. So in hypertension, there is both symmetrical enlargement of the interventricular septum and the left ventricular posterior wall. Whereas in hypertrophic cardiomyopathy, we have asymmetrical enlargement. That is, this is the view which we use to diagnose. And the septum is enlarged, whereas the posterior wall is thinned out. So that is how we differentiate between concentric left ventricular hypertrophy of hypertension to hypertrophic cardiomyopathy. So, other investigations such as a CT scan, CT abdomen. Here we can see clearly, this is a suprarenal mass of pheochromocytoma. So this is a tumor which secretes the VMAs, what we call as vanillin mandelic acid, metanephrines and normetaphrines, which are the hormones which elevate the blood pressure and is one of the important cause of hypertensive crisis. And the definitive treatment would be removal of this pheochromocytoma causing tumor. So this is another important cause of secondary hypertension. This is renal artery stenosis. This is a CT iotogram. You can clearly see the descending aorta, which is also diseased. So it should be uniform and smooth. But here you can see these are the lesions here. So that means there is evidence of atherosclerosis in this patient. And this is the right renal artery, and this is the left renal artery. So the right renal artery at the origin, or the ostium as we call it, has 99% stenosis, and the left renal artery just beyond the origin or the ostium has almost 80% stenosis. So renal artery stenosis is a very underdiagnosed and an important secondary cause of accelerated hypertension. And the treatment of renal artery stenosis would be, because if patient is not controlled with medication, we have to stent the renal arteries, and then the blood flow to the renal vasculature improves and the blood pressure of the patient will come under control. So why is it very important to discuss all these factors? And this when now we are coming to the management part of the patients with hypertensive crisis. So like we have already discussed, hypertensive crisis is defined, is divided into emergency and urgency. So, in a patient with emergency, there are certain guidelines for controlling blood pressure, whereas in urgency, there is a certain guidelines for controlling blood pressure. So where do these guidelines arise? It is not out of one's experience, it is out of a lot of research and physiology. So, our brain or the cerebral autoregulation as we call it. So whenever there is hypotension or hypertension, the body regulates blood flow in such a way that the most important organs, such as the brain, the heart, the kidneys, and the liver, receives most of the blood supply, whereas the skin and the musculoskeletal system, which is considered to be less important rather than the vital organs, the blood circulation to them goes into vasospasm and they reduce the blood supply. So the pressure in the brain is maintained by what we call as a cerebral autoregulation. And this autoregulation is maintained at the mean arterial pressure between 60 and 120 millimeters of mercury. That means at this pressure, the vasoconstriction and vasodilation of the cerebral vasculature is at optimal levels. Whereas if the mean arterial pressure goes above 120, there is a failure of autoregulation, which results in cerebral hyperperfusion. So we all know that cerebral hyperperfusion can be detrimental to the patient because sudden increase in blood supply to the brain can cause cerebral edema. This cerebral edema can lead to hypertensive encephalopathy, causing drowsiness of the patient and altered sensorium, and can lead to even respiratory arrest and respiratory failure. Whereas if the mean arterial pressure is less than 60, hypoperfusion can lead to cerebrovascular insults and infarction in the brain. So in patients with chronic hypertension, this cerebral autoregulation is shifted to the right side. In the sense, in a normal patient, it is between 60 to 120, whereas in a chronically hypertensive patient, the body or the brain gets used to the hypertension. That is the increase in levels of blood pressure. So the brain can auto-regulate the perfusion even up to a level of 160 millimeters of mercury. So in a patient with chronic uncontrolled hypertension, so even between 60 to 160, the cerebral autoregulation occurs. So that is a sort of protective mechanism the brain develops by itself to protect itself from the regulatory effects of hypertension. So this is cerebral autoregulation. So the cerebral perfusion pressure, as CPP as we call it, is below the lower limit of mean arterial pressure of 60. There can occur hypoperfusion with ischemia. Whereas if the cerebral perfusion pressure is above the upper limit, there can occur breakthrough vasodilatation. And once there is breakthrough vasodilatation, there are certain segments in the brain which go into pseudospasm and fluid extravasation, leading to cerebral edema, increased intracranial tension, and a patient can land up with hypertensive encephalopathy and coma. So our next and the most important question is in a patient who presents to us with a hypertensive emergency. So how far can the BP be safely lowered? So this is the $1 million question. And there are a lot of research which had gone into this. And ultimately they have come up with the answer that the lower limit usually is 25% below the mean arterial pressure on arrival. So if the mean arterial pressure, so I think we all know how to calculate the mean arterial pressure. So systolic blood pressure minus diastolic blood pressure is known as pulse pressure. So mean arterial pressure is diastolic blood pressure plus 1/3 of pulse pressure. So on arrival, we should calculate the mean arterial blood pressure, and we should aim for a lower limit of 25% of mean arterial pressure over a period of 1 to 2 hours. And from there, if the patient is fine and there are no neurological complications of hypoperfusion and no other target organ damage, then we can slowly bring down the blood pressure. So this was based on a study in which 50% of chronic hypertensives reached lower autoregulation limit of the cerebral perfusion pressure with only 11 to 20% reduction in mean arterial pressure. So, it was said that most ischemic complications develop with reductions of greater than 20 to 30% over 1 to 2 days. So an ideal level or safe level of reducing blood pressure in a patient with hypertensive emergency would be to a level of mean arterial pressure, which is 25% less than the time of arrival within the first 1 hour. And after that, it should be slowly brought down to a diastolic blood pressure of 110, and then over a period of 24 hours, and then slowly brought down below diastolic blood pressure of 110. So what happens if you bring it less than 25% mean arterial pressure rapidly is there is hypoperfusion in the brain leading to infarction, which can cause blindness, paralysis, coma, death, or myocardial infarction due to hypoperfusion to the various target organs. So these are the therapeutic guidelines. So which state that BP should not be lowered more than 20%. What we are talking about here is the mean arterial pressure over the first 1 to 2 hours. And again, there is a twist to this. This is in 90% of the cases, but in another 10 to 15% where there is ongoing target organ damage. That is, patient has ongoing pulmonary edema, patient has ongoing myocardial infarction, patient has ongoing kidney injury, patient has papillary edema. In such cases, we can still get it down to almost 30% or slightly lower than that until the target organ damage is rectified. And after the first 1 to 2 hours, the diastolic blood pressure should be brought down to 110 for patients, and for normal levels may not be very safe. And below 110 of diastolic blood pressure, the reduction should be gradual in a matter of 1 to 2 days. And all throughout this 1 to 2 days, the patient has to be strictly monitored for signs of neurological worsening, such as a CVA or hypoperfusion, such as drowsiness, or a patient going into coma. And this monitoring ideally should be done in an ICU setting. So that is a hypertensive emergency. And in hypertensive urgency, we all know that there is no target organ damage, but there is elevation of blood pressure to more than 180 by 110 millimeters of mercury. And rapid reduction in BP in such patients may be associated with significant morbidity due to organ hypoperfusion, leading to ischemia and infarction. Hence, the BP should be lowered gradually over the first 24 to 48 hours. And in such cases, oral medications are advisable as compared to the IV medication. There are a few exceptions to these conditions in which hypertensive emergency, where only 25% or 30% of BP should be reduced. And one such exception is aortic dissection. We have typically seen these cases presenting with tearing chest pain radiating to the back with unequal pulses. Most commonly, any patient comes with hypertensive emergency, let me specify here that we need to examine for all the 4 pulses in all the 4 limbs. So because one of the most important differential diagnosis is aortic dissection, and in these aortic dissection, we get unequal pulses because one of the subclavians can go into the false lumen, resulting in spuriously low blood pressure in that limb. So in dissection, we need rapidly lowering BP over for first 5 to 10 minutes with the systolic blood pressure and less than 120 and a mean arterial pressure to less than 80. And the other exemption is the cerebrovascular accident or the ischemic CVA, because in patients with ischemic CVA, the increase in blood pressure is a protective physiological response to maintain cerebral perfusion pressure. And because of the impaired autoregulation, and it is always essential to maintain high blood pressure in patients with ischemic CVA. Otherwise, the penumbra may be at risk. So to save the ischemic penumbra, that is the area surrounding the initial focus of infarct, we have to maintain high blood pressure. Whereas the only areas where we need to reduce blood pressure in ischemic CVAs, if the systolic blood pressure is more than 220 and diastolic is more than 120, or if there is any other end organ damage like acute MI or pulmonary edema, or if the patient is planned for thrombolysis, in such cases, we need to reduce the blood pressure to less than 185 by 110 millimeters of mercury. So in patients with hypertensive emergency, like we have discussed, we use many agents intravenously. So, what should the optimal characteristics of such drugs be? So ideally, they should be easily titratable, that is fast onset and short duration of action, and minimal reflex sympathetic activity, because after stopping the drug, they should not have rebound hypertension. And they should be devoid of side effects or drug interactions. And there should be lack of tolerance or tachyphylaxis, because in few cases, we may be using the intravenous medication for at least 24 to 48 hours. And if the patient develops tolerance, then the medicines may not act. So, these are the very commonly used intravenous agents in both ER and in ICU setting for cardiology. Out of which, let me highlight here the most important of which are nitroprusside. Sodium nitroprusside is given as an IV infusion in the dosage of 0.25 to 10 microgram per kg per minute. And it has an immediate onset with a duration of action of 1 to 2 minutes. And we should be very careful, because in the doses of more than 10 microgram per kg per minute, sodium nitroprusside can cause cyanide toxicity because it's decomposed to form thiocyanate in the body. And we commonly use IV labetalol and IV nitroglycerin. So IV labetalol can be given as a bolus or an infusion. If you give it as a bolus, it should be given as either 10 or 20 milligram bolus dose, and can be repeated every 10 minutes to a maximum dose of 80 milligram. And onset is 3 to 5 minutes with the duration of action is 3 to 6 hours. If you give labetalol IV infusion, it can be given between 1 to 2 milligram per minute. And nitroglycerin, NTG, as soon as IV infusion, it started at 5 microgram per minute and can be increased in dosages of 5 microgram, that is 5, 10, 15, 20, so on, up to 300 microgram per minute. Again, the duration of onset is 1 to 2 minutes, and it acts for 1 to 3 minutes. So nicardipine, phenoldopam, and esmolol is a beta blocker. And phentolamine is very important because this is the drug of choice in pheochromocytoma. Can be given as IV bolus, 5 to 10 milligram every 10 minutes. Again, short onset, 1 to 2 minutes, and duration of action is 10 to 30 minutes. And enalaprilat is the only IV form of ACE inhibitor. It's given as IV bolus of 0.625 to 0.125 milligram every 6 hourly, and duration of action is 6 to 8 hours. Point to be noted here is labetalol and esmolol are inherent beta blocking intravenous infusions. Hence, they are contraindicated in patients with bradycardia and heart blocks. So these are certain scenarios. So like I discussed, pheochromocytoma. In patients with pheochromocytoma, it is essential to block both the alpha and beta blockers. Hence, phentolamine has been classically the drug of choice, but even levetolol and nitocloside can be effective. So in pheochromocytoma, especially in crisis, always an alpha blocking agent should be given prior to administering a beta blocking agent. So we have always already discussed aortic dissection. So the goal is to reduce the shear force and pressure by time. And the goal is a systolic blood pressure of 100 to 110, which can be achieved with a beta blocker and a titratable vasodilator. So the treatment of choice would be levetolol, as it provides both beta blockage and vasodilatation. And the second would be nitocloside. And in patients with many pregnant females, you have seen with preeclampsia and eclampsia. And this is one condition where the diastolic blood pressure should be reduced to 90 to 100 millimeters of mercury, and not more than that, because a precipitous drop should always be avoided, as it can compromise the placenta circulation and affect the baby. And the treatment of choice in eclampsia and preeclampsia is either levetolol or hydralazine, and even nifedipine can be used, which is a calcium channel blocker. Yeah. So thank you very much. And any discussion or questions you can take.
Right, that was an excellent and extensive talk on hypertensive emergencies and urgency, how we are going to deal with ED as well as the continuum of the care. Yeah, we have a few questions here posted by participants. First, we start with one question like, how do we differentiate between hypertensive emergency and urgency? I think this was spoken by Dr. Tapashri. I think you can take this question, Dr. Tapashri.
Yes, sir. Hypertensive emergency and hypertensive urgency can be differentiated very easily based on two components. Both the conditions have increased blood pressure, that is blood pressure systolic over 180 and diastolic over 110. Hypertensive emergency, additionally, there'll be a target organ dysfunction. That is, it may involve brain, heart, or kidney. Whereas in hypertensive urgency, it is also called as asymptomatic hypertension. That is, no organ is involved and you see hypertension alone. This is a very easy way to differentiate between hypertensive emergency and hypertensive urgency.
Yeah, now second question, what are the sequelae for hypertensive emergency? I welcome Dr. Kiran Kumar Verma, HOD Emergency Medicine at Yashoda Hospital, Malakpet Unit. Please come on to the stage, sir, and then please take this question. Yeah,
thank you, Dr. Suresh. And then thank you, Dr. Tapashri and Dr. Rohit Reddy, so for your enlightening on hypertensive emergencies and the involvement of cardiac and thank you. It was really nice talk, presentation both by you, Tapashri and Rohit Reddy, sir. Thank you, sir. Then comes to our question. So what are the sequelae of hypertensive emergencies? Yes. As Tapashri said, hypertension, first we need to differentiate between hypertensive urgency and hypertensive emergency, because treatment entirely differs. If the hypertensive emergency treatment is different, hypertensive urgency treatment is different. Because based on that only, we are going to control the BP. If it is urgency, we don't control aggressively. If it is hypertensive emergency, yes, we need to. But as our Dr. Sir said, so we have our own protocol, how much to be controlled over a period of 24 hours. then we need to take care of emergency. So for that, we need to differentiate between hypertensive urgency and emergency. Then when it comes to our question, what are the sequel of hypertensive emergency? Yes. Hypertensive emergency means there should be end organ damage. We divide into three categories like cardiopulmonary involvement, then central nervous system involvement, then kidney involvement, renal. So when it comes to that kidney involvement, there may be like renal insufficiency, acute renal failure. When it comes to cardiopulmonary, it's like myocardial infarction, acute LV failure with pulmonary edema, sometimes aortic dissection, sometimes it may present as unstable angina as well. Then when it comes to central nervous system, sometimes it may be like presented with CVA, acute CVA, subarachnoid hemorrhage, sometimes bleeds, then encephalopathies as well. So this way we will categorize into three categories. First, cardiopulmonary involvement, renal involvement, and central nervous involvement. That's all.
Yeah. Thank you, Dr. Verma. And there is another question. Hypertensive retinopathy, can we diagnose in ED and what is the significance? I think I will take this question. What is hypertensive retinopathy? Coming to pathophysiology, we all know like retinal blood vessels, they have a distinct features like which is differentiated from other blood vessels. Absence of sympathetic nerve supply, and then there is auto-regulation of the blood flow, presence of blood retinal barrier, but increase in blood pressure, above the normal levels, they could lead to initially vessels to constrict, and then over a period of time, this increase in blood pressure overcomes this phenomena, that is compensated on, and it could damage the muscle layer as well as the endothelium. So what are the changes, what we can expect here? So they develop late in the stage, and then fundoscopic examination show arterial constriction, AV thickening, AV nicking, vascular changes, and then the flame-shaped hemorrhages, cotton wool spots. These are all can be seen during the fundoscopy. Yes, I think if you are familiar with the fundoscopy and ophthalmoscopy, yes, you can have a you can train under ophthalmologist, or otherwise you can just with a neurologist or anyone when they are seeing fundoscopy, just you can learn over the period of time. Yes, you could diagnose the hypertensive retinopathy in ED, provided you got a adequate training. Yeah. There is another question. I asked Dr. Rohit sir to take this question. What are the management goals for hypertensive emergency and urgency?
Yeah, I think, so this will just be a repetition of our topic. So,
Yeah.
So hypertensive emergency has end organ damage or target organ damage. So BP has to be reduced immediately with the help of intravenous agents. And like we said, based on the cerebral autoregulation, history of hypertension is very important. So if the patient already has hypertension, a chronic hypertension, so we know that cerebral autoregulation can occur even up to 160 millimeters of mercury. So in such cases, we can reduce it maybe up to, in the first hour, mean arterial pressure should be reduced up to 20%. And just keep monitoring. If there is target organ damage is still persisting, we can reduce it to up to 25%. And then from 1 to 2 hours to the next 1 day, we should the target should be diastolic blood pressure around 100 to 110 millimeters of mercury. Ideally, they say 110, but that is only theoretical. We know it is practically very difficult to keep the BP only at 110. So it keeps fluctuating around 110. So between 100 to 110 should be fine. And then from the second day onwards, we can start getting it down to the normal blood pressure levels or the higher limit of blood pressure in a hypertensive emergency. Whereas in a hypertensive urgency, so there is no need for using intravenous agents. We can start with oral antihypertensive agents, and the reduction of BP should be gradual over a period of 2 days, that is 48 hours. So we would target again 25% over a period of 2 days. So, then again after that, once the patient gets used to the reduction in BP, then it should be stabilized.
Yeah.
One thing I wanted to point out, Dr. Suresh had a very good pathophysiology for explaining retinopathy. So the same thing happens in the brain also, basically. So when the BP suddenly shoots up, the brain protects itself by going into diffuse vasoconstriction. So what happens is, despite that, if persistently there is an increase in blood pressure, then the blood pressure overcomes the vasoconstriction, and certain areas in the brain keep going to vasodilatation. That means they just give up, and that is where the bleeds can occur, or the cerebral edema can occur. That is why we see the bleed and the midline shift. and everything. So that is why, in encephalopathy or any target organ damage, it is imperative to bring it down, for at least 20% within the first 1 to 2 hours.
Yeah, there is another question to answer. We often hear a lot of terms like accelerated hypertension, hypertensive crisis. What exactly to write in the working diagnosis? Many have a doubt also. So what exactly these? Yes.
Yeah, I see. Crisis in a broad sense, English definition means some problem. So basically, any elevated blood pressure is called hypertensive crisis. So crisis is divided into hypertensive emergency and hypertensive urgency. So that we have already discussed. So any patient with chronic hypertension experiencing chronic end organ damage is known as malignant hypertension. Whereas if a patient comes with elevated blood pressure and signs of retinopathy, as per the Keith Wagner classification, class 1, 2, 3, 4, any of the signs of retinopathy, then it is called accelerated hypertension. Retinopathy without other end organ damage is accelerated. Beyond that, it is either hypertensive emergency.
Okay, thank you. And any latest developments, especially in the management of hypertension?
Yeah, definitely. That is why, it is very imperative. See, when the patient comes to here, actually, when I was given the topic, I wanted to give it a very practical approach rather than going into pathophysiology, physiology, anatomy, which everybody knows and everybody is good. A very, a practical approach of how to deal with the patient in the first 1 hour, how much we should bring it down, what are the agents we use and the dosing, so that it will be very helpful. So, it is very essential to determine the underlying cause of hypertension. That is why, clinical examination is becoming a lost art. I can understand with, the ER being so busy and, so much pressure with so many infectious cases and other cases. But at least when there is time, we should always look for secondary causes. Always in a patient with hypertension emergency or crisis, you should always examine all the 4 pulses, because it can be a dissection. When you have unequal pulses, always suspect aortic dissection, Takayasu arteritis, or atherosclerosis. These are the 3 differential diagnoses. This keeps narrowing down. So, we have IV agents, which we have already discussed, and oral agents, which are the class 1 indication is angiotensin receptor blockers, ACE inhibitors, and calcium channel blockers. And second line drugs are the beta blockers and alpha blockers, centrally acting, and diuretics. So despite patient having, adequate medication with oral drugs, still BP is not controlled in many of the patients which we see coming back to OPD. Like I told you, we need to treat the secondary causes, such as sleep apnea. We have seen many people with sleep apnea, you put them on CPAP, come back with controlled BP after a month or so with the same medication. And coming to the newer advancements from our cardiological point of view, we are looking into many newer advancements like therapies. So like we told you, for renal artery stenosis, renal artery stenting is definitely a definitive treatment, and helps in controlling blood pressure, which is in patients with resistant hypertension. So, and not only that, if patient BP is uncontrolled with multiple antihypertensives, now we have what is called as carotid hyperstimulation. It is a small device which is placed in the carotid here. So basically it stimulates the carotid sinus and helps in lowering BP. And the most important now is there are studies going on for renal denervation therapy. So patients with resistant hypertension, uncontrolled with multiple medication. So there's a procedure in which the renal nerves along the renal arteries can be ablated by using radiofrequency ablation. So, in that, actually the initial trial, which was the Simplicity trial, had shown the efficacy not high and high rate of side effects. So this was put into the background. But recently in the ACC 2020 and 21, the recent trials have shown very good benefits based on the operator experience, that this renal denervation therapy has shown significant benefits in patients with resistant hypertension. So let me define resistant hypertension. Is the patients with uncontrolled hypertension despite 3 antihypertensive medication, out of which 1 should be a diuretic. So this is a normal guideline. When you go for 3 antihypertensives, 1 of them should be a diuretic. And despite that, if patient is having resistant hypertension and uncontrolled hypertension with 3 or more drugs, then they are the candidates for this renal denervation therapy. Still, very early stages in India, but more and more people are using it. And with more and more good clinical trial data, I think it should come into clinical practice very soon.
Okay, thank you. There is one question, general question, like a patient enters emergency complaining of SBP at home 200. I think that could be due to the electronic machine, could be. I think then you found it like blood pressure was around 140 over 80. So apart from cardiology opinion, what we can do?
No, see, the different classification of hypertension, which is what is called as masked hypertension. That means patient has blood pressure, but when he comes to the hospital, we are unable to pick up, maybe because of the fluctuations. And see, BP is not a straight line throughout the day. There are fluctuations in blood pressure. So early morning, when you get up, your BP is lowest. Then again, it slightly increases. Then based on your work level, stress, evening 4 o'clock, 5 o'clock, it is high. And then you should have a nocturnal dip. That means at 6 or 7 o'clock, compared to your morning level, your BP level should be almost 20% less. But if you're not having that, then you're tend to have increased hypertension. So masked hypertension is a condition in which patient has hypertension, but when he goes to a doctor or office checkup, that is what they call it in the UK, US, office checkup, blood pressure is normal. So he is labeled to be a normotensive. So this is what is masked hypertension. There is one more condition called white coat hypertension, in which patient has normal blood pressure. But when he goes to a doctor, it's called white coat because when he sees the white lab coat, he gets stressed or he gets anxious and BP shoots up. So he's wrongly labeled as having hypertension. So now the best way of determining whether he has hypertension or not, and all the guidelines do recommend, rather than a single BP reading, is what we call ambulatory BP monitoring. So what we do is you connect the patient to an ambulatory BP monitor. So that is a BP machine which records for 24 hours. Even when the patient is at home, when he's doing his routine activities, patient can be totally normal. He can do his routine activities, go to work, do whatever he wants, and the machine keeps recording. So next day they remove it and you can analyze the reports. And if it is, and we get what we call as average BP reading, more than 135/85, definitely it is hypertensive. It needs to be treated. And the loss of nocturnal dip is one more thing which we see. If BP is normal and loss of nocturnal dip is there, then there is a high likelihood that in the near future he may develop hypertension. So ambulatory BP monitoring should be the investigation of choice in such patients.
Yeah, I think other questions posted, I think well explained in the talk itself. I think we're near the time, and I thank you very much for both of you, Dr. Tapashri and Dr. Rohit Reddy sir, for giving your valuable time. Okay, and then as well, Kiran Kumar Oma, he was always supporting for the sessions. And thank you very much, and have a nice day.
Thank you, sir. Thank you all.
Yeah, thank you.
Good day.